So Scott, uh, I know we talked a little bit before, and shout out to Adam Petway. He's my boss, my mentor, my friend. He specifically said that you would be one of the smartest guy I ever had. So like, can you introduce yourself a little bit?
That's very kind of Adam, but yes, Scott Epsley, sports physical therapist, originally from Australia, moved to the US in 2008. Um, Worked at Georgetown Athletics for about 8 years, and while I was in DC, was also consulting with a bunch of the pro teams and through the parent company there, MedStar, who the medical providers for Capital at the time were the Capitals, Nationals, and Wizards. So it was we built a performance program there, and then would do some consulting with the respective pro teams, and then ended up in Philly as director of physiotherapy for the 76ers, and then medical director for the 76ers. And since then, have since leaving there, have been a consultant, private consultant, working with individual athletes, teams, helping set up health and performance teams, or assisting other health and performance teams with consults on individual cases, as well as I said, treating individual players.
Cool, cool. So, uh, personally, I want to know that, like, what are the difference between working at Australia and working at the state?
I think the biggest difference is probably, the multidisciplinary team and the makeup of that. Obviously, in the United States, we have athletic trainers as well who form an important part of our multidisciplinary team. In Australia, we don't. So it's really, the physical therapist, the sports scientist, the strength coach, working as a unit. And then, of course, you have your external medical providers or what have you. But here, there's less, I guess, of the acute on-field or on-court care for the physical therapist. Just to generalize, that's not true of every sport. But yeah, and a little bit more focus on the rehab side of things, whereas we're trained in Australia for all of that, and so have an on-field and on-court presence as well as the rehabilitation side of things.
Cool, cool. So, I know you collaborate with Adam about like the Achilles tendon paper and the ACL tendon rupture paper. So, like, sorry, ACL rupture paper. So, um, those two like are amazing papers that like a lot of like physical therapists, a lot of like sports scientists I talk with, they're on the pro setting. They like those papers. So I want to start by like asking, like, what get both of you started to do like these two papers?
Yeah, at the time I was working with an individual athlete in Philadelphia, and I was just living up in Philly for this athlete during the week and traveling back home to DC on weekends. And Adam and I caught up for a coffee, and we just got chatting about some of the injury trends that we were seeing. And I think there'd been a couple of recent Achilles ruptures, not just in the NBA, but there seemed at the time to have been this kind of increase in incidence of Achilles tendon ruptures. And then we got chatting a little further about ACLs, and we just started talking about, well, the mechanism in basketball, and is there a distinct pattern that we could identify that is kind of the biomechanical pattern and how basketball players rupture, and it went from there.
So, can you can we start by like talking what are the biomechanics like what are the mechanics like um athlete tend like basketball player tend to hurt their like or tend to tear their ACL and Achilles tendon.
Yeah, so if we think about the Achilles first, we've identified basically a dorsiflexion, an extended knee, usually in some degree of hip extension, and external rotation of the tibia or foot in what we call the false step or step back type position is almost exclusively how basketball players rupture their Achilles tendons. Now, this is a little bit distinct from football or soccer, where it can be in full stride and sprint, but typically accompanied by that external rotation of the foot as well. So we did not see that in any of our basketball cohort for our paper, but we certainly saw this false step, back step mechanism, sometimes associated with stepping to the side as well, whereby you're kind of asking the tendon to do three things at that point in time. It's kind of, breaking from a lateral movement as you're changing direction and then accelerating into a new movement. And so the tendons kind of, getting wrung out, as it were, and being kind of pushed to end of range. We also found, the degree of dorsiflexion was pretty high. So we're talking off the top of my head, I think we found it was around 48 degrees was kind of the average, which most of our basketball players would have somewhere between 30 and 35-degree knee to wall. Some guys obviously a lot less if they've had chronic ankle sprains. We know that dorsiflexion increases during the time that you play as your body heats up and the soft tissues kind of, are stretched out from the act of playing. You probably gain about 5 more degrees, but that still is, well outside of most people's normal range of dorsiflexion. Some of these mechanisms aren't particularly high force, which, is interesting. That seems like, and again, we didn't calculate with inverse dynamics, although we've talked about going back and looking at that. But, it doesn't seem like they're particularly always, a very, very high force maneuver, which is very interesting, but certainly this kind of terminal range and wringing out of the tendon, in terms of looking at, the failure of the Achilles tendon from a stress strain perspective. It's interesting. The literature is a little bit equivocal, and somewhat the difficulties of calculating strain to failure of the tendon in ex vivo in a jig, and how you fixate the tendon, and the fact that you don't have the other series elastic element of the gastrocsoleus complex on the other end, kind of makes it difficult to evaluate as it would behave in vivo. In vivo, you see, again, differences from people who've done kind of, finite element calculations of where that strain to failure would occur. And so, it's a little bit hard to know, with respect to that range of motion and the lengthening of the Achilles, and what, whether it is just that strain to failure or whether there are other components in terms of pre-existing pathology or what have you, which we kind of suspect from some of the other histology literature that most of these probably do have some degree of pre-existing pathology that may be asymptomatic at the time. But that's pretty much, I think, the overview of the Achilles rupture. If we look at the ACL ruptures, again, we excluded direct contact with the knee in our paper intentionally, because those can often be, multi-ligament injuries or have concomitant other internal disruptions, such as meniscal tears and chondral, injuries, which I'm not saying you can't get with a non-contact ACL, but certainly the higher velocity of the direct contact injury lends itself to some of those other pathologies. So we kind of excluded that and just wanted to look at ACL injuries without direct contact to the knee. We found that most of these injuries occurred with some kind of contact to the body elsewhere, which was some sort of perturbation. And we see that in most sports, to be honest, but it kind of preceded the foot strike or the landing contact that then was the contact at time of rupture. So that was the first thing, was just identifying that. We looked at some literature from some other groups that had investigated basketball, and we certainly identified that it seems like men and women do tear their ACLs differently in basketball specifically. Um, we found three sort of distinct mechanisms. One was, kind of striding outside of the base, um, or support well outside of the base on a very dorsiflexed ankle. Um, Typically again with a contact that had preceded that kind of set off a perturbation that may have altered the ground contact point, or the anticipated ground contact point from a cognitive standpoint. The second was coming to a very abrupt stop, or a jump stop, in a kind of what we call a pro hop situation. And we found in those situations excessive posterior trunk lean, and then digging into some of the other biomechanical literature, this idea of kind of hip flexion to knee flexion mismatch. So not so much the peak angles, but the actual rate at which the hip flexion and knee flexion was occurring. So if knee flexion is sort of occurring more rapidly, and you're in posterior trunk lean and you've got, delayed hip flexion, that tends to be a risk factor, because you get a massive quadriceps contraction without kind of slowing of the momentum from the rest of the trunk. So we found that as another mechanism. And then the third was landing from a jump, again, usually contact in the air, ipsilateral trunk lateral flexion. I mean, if you watch any basketball game and you watch, somebody, getting contact in the air and taking a rebound, it's quite interesting how many times players land with this. The opposite leg, contralateral leg abducts to counterbalance the trunk. The trunk laterally flexes over the landing leg, and why one ruptures and one doesn't, is still something that we want to investigate and look at. Okay, basketball players perform these movements thousands of times. Why this time? There's, we think typically a cognitive element of that as well. There can be a proprioceptive element with cervical spine, attention element of being distracted by, something else that's going on in the play, whether it's, ball, defender, what have you. But those were the three main things. We believe as a group, most of these occurred with, as we know, the timing of the ACL ruptures probably around that 50 millisecond, or within that 50 milliseconds of initial ground contact. If you look at that, there was kind of this very early initial tibial internal rotation moment, which is where we believe, with the anterior translation, rapid quadriceps contraction, and tibial rotation, is probably where the rupture occurs. The secondary, valgus external rotation, adduction collapse, we think is probably a secondary thing, from almost like a pivot shift mechanism there once the ACL actually goes. I know that's, kind of going to be highly debated, and there's people that would disagree with that. But, if you look again at the biomechanical literature of just how much valgus you would need and external rotation to actually tear the ACL, it's a lot, and you would, disrupt your MCL and various other capsular structures at the same time, which we don't see necessarily in isolated ACL injuries. So we think that probably, about 85% of these probably actually have this really rapid internal rotation moment at the beginning, and then they secondarily kind of shift and end up in that valgus collapse. So that's our ACL overview.
Cool. So this brings me to another question, that these movements that are like you mentioned, it happens like to basically all the players and a lot of players, but so does that mean like, does like these paper mean like we should ask our athlete to avoid these movements, or like is there a way to train them to like be more strong at these like positions or like
So one of the things that we really believe is that, injury prevention has been historically predominantly put the onus of that has been put onto the performance and medical staffs in high performance sport. And, we're making the argument that, in fact, technical skill development forms, a cornerstone of injury prevention. And so teaching somebody, for instance, a skip step in an appropriate situation on a drive to the basket as opposed to an excessive false step, back step in a drive to the basket, could be really important. And in terms of injury prevention, teaching somebody the appropriate amount of or appropriate trunk position and getting the appropriate amount of hip flexion and trunk flexion, um, you know, in a jump stop position is really important. And so, I don't think you can take away, the technical skill development aspect of basketball and isolate that and say that, it's just a matter of strengthening somebody or improving their proprioception or what have you to prevent these injuries. Now, that obviously follows then that they still need to have, the capacities to decelerate, the capacity to maintain foot and ankle stiffness so that they don't get into excessive ankle dorsiflexion. They need to be trained to be able to backstep and then, drive off that without external rotation of the ankle. They need to be trained to be able to decelerate in a sagittal plane without necessarily, too much internal rotation of the tibia, which is a very common basketball thing to do. In terms of decelerate, then kind of rely on the hip and the hip structures to aid in that deceleration, especially if there's deficiency in eccentric control through the quads. So I think the answer to your question is it's multifactorial. Our technical skill development coaches are really an important part of our injury prevention pathway, as well as then kind of these matrices of capacities to be able to do the technical skill really well and repeatedly in a safe way.
cool, nice. I like it. I like it. So, uh, let's say after athletes suffer from ACL injury, um, can you walk us through like the process of like return to play? I know this is a big one.
Yeah, I mean, yeah, I think rehab probably over 300 ACLs in my career. I've seen ACL rehabilitation evolve over the last 25 years. We've been through many iterations of these, accelerated return to plays, get them back in 6 months, make sure they've got full hyperextension, the Shelbourne era, through to now we're much more conservative. We realize that, some of these, disruptions to the neuromuscular timing and firing are still present up to 2 years down the track. And so, the focus is on trying to continue to improve performance even after the ACL is returned, not returning them until around that, 9 to 12 month mark, depending on the sport and the surgeon. So there's that. There's just the time frames and how we're approaching those. There's the different grafts which make a difference and they tend to be regional. You go to different parts of the world, and they're going to do different grafts. We did a lot of hamstring grafts in Australia. There's a lot of bone patella tendon grafts in the US, and our quadricep tendon grafts. Some of those have their own unique, issues with them that need to be factored into the rehabilitation process as well. So, just thinking about, when you're going to do, high load on the hamstrings and high speed hamstring rehabilitation with a hamstring graft is going to be very different to when you're going to do it with a bone patella tendon graft. Bone patella tendon graft, obviously, risk of getting some patella tendinopathy. I've seen a couple of quadriceps tendons recently down the track that have not done, great and have developed, quadriceps kind of tendon pain, haven't really got their rec fems back. So then there's that kind of aspect of isolating different parts of the quadricep and making sure that all aspects of the quad are coming back in the rehab. Uh, the early use of open chain, um, again, hotly debated, but I think the evidence is pretty clear that it doesn't increase the laxity of the graft. That and using it through safe ranges or less ranges that place less strain on the ACL in terms of anterior translation associated with quadriceps contractions. So that kind of 60 to 90, and then terminal range using E-stim is now very common as well to facilitate quad. BFR has been an evolution in our rehabilitation to maintain muscle mass. The one thing I want to say about BFR is that maintaining the protein elements within a muscle does not equate to maintaining the series elastic elements and the remodeling that's required around those. And I mean everything from the enthesis to the tendon to the myotendinous junction, and then to the epimysium and the perimysium, which are all how we actually generate viscosity and rapid explosive movement. It's not through just a forceful contraction of the contractile elements and the sarcomeres. It's through the soft tissue elements and the series elastic elements. So you know, using BFR at low levels MVC, will maintain muscle mass, which is certainly important. But you've got to follow that up with thinking about all of the other capacities, and then thinking about adaptation and remodeling through all those other pieces. So, those are the really big things that I think about, with early ACL rehab. And then I think, moving into later stage ACL rehab is really how we bring in some of the cognitive challenges. We bring in the proprioceptive elements. I wouldn't rehab an ACL now without bringing in cervical spine kind of elements, because of the way that alters proprioception and jumping and landing. I wouldn't rehab without bringing in some kind of cognitive distraction, a cognitive task that somebody's doing during kind of a jumping landing task, or and then bringing in even trunk rotational elements. We really think that controlling trunk rotation, I looked at that in lacrosse at Georgetown many years ago, and pretty much all of the lacrosse ACLs were associated with making a pass and a large trunk, or a catch and a large trunk rotation element. And so making sure that you're covering control with all of these other elements, bringing in the cognitive challenges, and then just building in the complexity on the basketball court or on the pitch or on the field, wherever it is that you're rehabilitating. Again, making sure you've got those core fundamental skills, working with your skill development coaches, and then building in complexity and degree of difficulty. It's amazing. You can put a basketball player, into a catch and shoot situation, moving to their left or moving to their right, and you'll see whether they're decelerating off their inside leg and coming to an appropriate jump stop in a catch and shoot situation, or are they still favoring it, putting them into a Euro step situation? Are they able to actually control in those types of situations without defense or cognitive load or contact, and then gradually building the complexity from there, and adding in opponents, and then increasing the speed of the game, and what have you.
Nice, nice. So, um, you kind of mentioned the timeline that earlier you guys kind of like accelerated the process of return to play, and then now you kind of wanted to like take it longer for athletes to go back. So, uh, recently there's like I don't know if it starts from recently or like way back, but like there's a there's a thing called like speed-based return to play. That means like start doing like uh pogos, hops, like rudiment series, those kind of like plyometric, and progress it into like maybe a little bit like jumping, a little bit running, a little bit change direction, and put strength at the last part of the rehab return to play process, which is kind of the opposite of like the traditional approach. So can you share a little bit your thoughts on like these two approaches?
Well, I think the one you're talking about is really kind of focusing on neuromuscular control. Um, and I don't think you want to do that at the expense of strength, but I certainly am not averse to bringing in elements of the neuromuscular control that maybe were delayed later in the rehabilitation process in some of the more traditional models. And it was a very in series progression, from when you do one thing and then move on to the next and move on to the next. I think these things can be worked on in parallel together with each other. And I think it's important, that you have some form of neuromuscular, control element very early in the rehabilitation process as well. I think if you leave that right to the end, you're exposing yourself once you start the return to practice, return to play elements of the rehab process. Converse to that, if you don't do enough strength and you don't have strength endurance components as well as what we talked about just from the tissue graft healing, graft capacity, are you going to develop patellar tendonitis, quadriceps tendonitis from those grafts? Are you going to expose your hamstrings because you don't have hamstring strength from a hamstring graft? If you don't develop those capacities early, you're exposing yourself as well. So I think, I don't think there's, one way. I think you can do both in parallel.
Nice, nice. I like it. You definitely are one of the smartest. So, um, I'm gonna keep going in this like return to play like conversation. Uh, so is like the let's say we put both like kind of like you mentioned neuromuscular control and the strength part into it. Like how like let's say now like what are like the timeline you want them to like be able to like return to the field?
Well, again, you have to look at those elements and, the capacity. I think it can be different for different athletes for sure. Or I think you've got to also think about graft maturation and tensile strength of the graft. And, for me, you might be looking at returning somebody to kind of early on court or on field based movement patterns that are a little more sport specific very, very early, might be 5 months, 6 months, but you're not really stressing the graft in those movement patterns. You're just, building into the rehab program some of the sport specific elements. You've gone through your running progressions. You've added some deceleration control. You've added a little bit of jumping landing control. Now you're really ready to build in the sport specific element. Again, I don't want to imply that I wouldn't have an athlete on court or on the pitch doing things sooner than that because as early as they can touch a ball and do that safely, I'm all for safe integration of those things. But in terms of getting more sport specific from a return to training standpoint initially, which is what we're talking about, I'd be thinking around, that 5 to 6 month mark, and then you're just building some of those capacities as well, change of direction capacity. You're doing those in a very controlled way. You think about Taberna's, control to chaos kind of continuum, and I'd say I've always rehabilitated sort of like that. I think you're adding a little bit more uncertainty. You're looking at unanticipated, changes of direction, both offensively and defensively. And so you're sort of bringing those elements in around that 7 to 8 month mark, and then potentially you're reintegrating into team training, and it might be around that 9 month, mark. But it's going to vary from sport to sport. It's going to vary from athlete to athlete. In basketball, we tend not to put, people back at least at the elite level until about 12 months. We've just rehabilitated the end stage kind of return to training phase. A soccer player that I'm, was working with a team on advising on and kind of, it's around that 9 month mark. I think 9 months is probably the earliest from a graft maturation, tensile strength standpoint. I think we understand that, but obviously the longer the better in that regard. But yeah.
Cool, cool. So that's ACL. So now I want to talk about like I know it's probably like the same concept with ACL, but like can you talk like the same return to play process for Achilles tendon rupture?
Yeah, so I mean it's probably a little bit different in terms of the neuromuscular proprioceptive elements. We're really thinking about building capacity in the tendon. When you think about the Achilles tendon, one of the big problems in rehabilitation there is lengthening of the tendon. So you really want to avoid lengthening of the tendon. You want to get some early stiffness in the tendon. Um, you want to monitor and avoid getting a seroma in the middle of the tendon, which granuloma, which I've seen sort of happen. And then that kind of delays, your rehab. So there's all of these things to consider. Uh, we've seen different protocols, people, very conservative in the early phase, non-weight bearing, to a little bit more aggressive with fairly early weight bearing, but controlled in a boot, and then, heel rise, and then gradually weaning out of that, but getting, pretty early weight bearing. If you look at Karen Silbernagel's work at University of Delaware, where she compared kind of those two protocols and then looked at, ultrasound elastography to look at the development of tendon stiffness, basically, excuse me, with the early weight bearing group, you see that the curve and the development of stiffness shifts to the left. So you get a much earlier development of stiffness within the tendon, which I think she and I would argue is a really positive thing. And that what we want to see, as opposed to the delayed weight bearing group, it doesn't seem to change ultimately the lengthening of the tendon. But you want to avoid, early aggressive stretching into dorsiflexion. And the reasons that, as soon as you lengthen a tendon, you're going to lose power. After an Achilles rupture, you're going to lose 10 to 15% of your power anyway. And then if you get the more complex ones, or they've had a revision, or they've got a tendon transfer augmentation of the tendon, or any of those things, then it may be even more. So your real key philosophy here, or mine, is don't get lengthening at all costs. The dorsiflexion range will come back, and if you lose a little bit of that, it's probably advantageous. And make sure that you kind of you're developing early stiffness within the tendon. And then once you've got that, you can, you're looking at building, your capacities, and you need to think about just, calf muscle strength, soleus, gastroc. You're thinking about endurance capacities, then you're thinking about the actual tendon capacity. So, firstly, just the healing and maturation of the collagen within that matrix. And then the second part is, restoring some elasticity and elastic energy storage within the series elastic element of the myotendinous components and the tendon itself as it heals. So that's a progressive process that happens over time. You're probably looking at once you're safe, you may return to some sort of running around that 12-week mark, and then kind of build that, and then you return to play. Ultimately is, again, dependent on the athlete and the sport, but somewhere between that 6 and 9 month area. And you read different things in the literature depending on the different sport. But I think a couple of things I've seen there, I track these on ultrasound as they're healing, and a couple of things that I've seen is like this, development of this kind of granulomatous tissue within the tendon, and it's really squishy, and you might hit 12 weeks and you've still got that. I would not push running then, even though time-based rehabilitation, phase would say, oh, you can start running, and you can start, increasing sort of more the plyometric type loading, 12, 16 weeks. I wouldn't be doing that with somebody who has that. I'd be delaying that, and I have delayed that. And again, all to make sure, A, you don't get a re-rupture, and B, to protect any lengthening that you might get through the immature healing. And I've had good success with that. So I like to track them, make sure that you're not developing those problems as well. But yeah, it's just really about building those capacities. Obviously now, we have so much accessibility to isometric strength testing, for force plate testing. Some of the protocols for testing, knee flexed, plantar flexion versus knee extended. The reproducibility sometimes can be tricky, but yeah, looking at that, I use force plates as well. Obviously, looking at you have to look at the kinetics, not just the kinematics, and you got to look at both. You will tend to adopt more of a knee and a hip strategy if you're not able to use an ankle strategy. So it's kind of watching how the athlete is developing force or absorbing force when you're doing these force play tests, and then making sure you're identifying that, not just looking at the data as well.
Nice, nice. I like it. I like it. I like it. So, uh, those are like for ACL and Achilles tendon rupture return to play. Next thing I want to ask is like, now like in like no matter what sport, load management is a big topic right now for like strength and conditioning coaches for rehab side stuff. So, uh, I know there's like game day lift for baseball, for hockey, for basketball. So the thing I want to ask is like, uh, if if the tissue is not like injured, like tear, you didn't rupture it. Let's say muscle, tendon, and the bone. Like if it's just for like let's say a practice or a game, how long does a muscle need? Like how much time does a muscle need to like recovery from that? And same with tendon and the bone.
Yeah, I mean, I think that's a little bit of a too broad a question to be fair. I think that there are certain remodeling timeframes. We know that, for instance, tendon kind of peak procollagen type upregulation is about anywhere from that 48, 72 hours post bout of exercise, and then things kind of settle back down again, from Sean Docking's work there, as well, looking at UTC within tendon and seeing the changes on UTC and then about 72 hours post playing. But we know that in most of our pro sports here, the ones that you just mentioned, NHL, NBA, you're playing again within that time frame. So, you've got 3 to 4 games a week. So you don't have that 72-hour window. Some of that is also going to come down to just, how accustomed the tissue is to repetitive load. And it also depends on how much the type of load that you're putting through the tissue. So, the deceleration element is really important, the eccentric load, and how much are you actually getting any kind of protein element sort of change within the muscle as a result of the deceleration element versus the connective tissue changes and upregulation in connective tissue remodeling processes that are stimulated by that. Strain rate in almost across all tissues is the biggest precipitator of our biological adaptations. So sometimes you can put higher peak loads through tissue, but if it's at a slow speed, it doesn't have the same implication for tissue remodeling as high peak loads at a high speed. So strain rate is high, so the rate of deformation of that tissue is high. That's what stimulates the remodeling process. So that's true of bone. And we just talked about tendon. Well, bone can take 4 to 5 days to really kind of fully upregulate from an imposed stimulus. So again, in healthy tissue, those remodeling cycles, you probably are adapting over time to a consistent load, and you're probably actually dampening down some of those remodeling changes in these tissues. We know that happens in bone. We know that, in say cross-country runners or distance runners, it's good for them to have a period at the end of a season where they do sort of reset, because you get decreased bone remodeling with just recurrent exposure to the same high volume of running. And so there's that element of it as well. And maybe one of the things we see now is we don't get that in, say, the NBA, where there's, all of these off-season leagues, off-season training, summer league, et cetera, et cetera. And it's worth keeping in mind that sometimes that can be helpful. Converse, it can be disadvantageous too, because we saw in our off seasons with our track runners at Georgetown the development of Achilles tendinopathy when they just shut down and did nothing. So what we did to mitigate that was just keep a couple of days a week of some shorter, higher intense bouts of run through type activities, just to keep a little bit of load in the tendon without actually putting volume through the body. So it's a long-winded answer to your question, but I think hopefully that explains it in a little bit more depth from a biological basis.
Yeah, of course, of course. I love it. I love it. So, um, man, I gotta say, Adam's right. You are like really, really smart. So basically, that's all the question I have for you today. So for those who are interested in what we're talking about today, where can they reach out to you?
Yeah, they can find me on LinkedIn and Twitter. My name, Scott Epsley. Just search that, and then more than happy for them to connect with me there and go from there.
Cool, cool.